What's up, everybody? It's the Vibe Check. I'm your host, TK. Today we're interviewing Dr. Toe. He's board certified in cardiovascular disease by the American Board of Internal Medicine and the National Board of Physicians and Surgeons. He serves as the section chief for cardiology as well as the medical director for congestive heart failure at, and vascular imaging, the largest medical group in northern Nevada. In addition to his clinical and leadership roles, Dr. Toe is an assistant professor of internal medicine at the University of Nevada, Reno School of Medicine. He is also a husband, father of three, real estate mogul, and someone I've really enjoyed working with over the past year. So, Dr. Toe, this is round two of the vibe check. Thank you so much for being so accommodating with technical difficulties. But I want to jump into it. This is something that I recently learned about heart failure, and we're going to talk a lot about heart failure today. Is when you're diagnosing heart failure, is it correct that you can see elevated collagen in lab tests when diagnosing? I think it's HFpEF. And right now, I look in Costco, I look in grocery stores, there are so many collagen supplements that you can buy. Do you think for a patient who has a high risk for heart failure or has heart failure, is that something that they should stay away from since they're adding more to what might already be a symptom of the problem?
Yeah, thanks for having me. And heart failure is a complicated subject, right? So in terms of testing for diagnosis of heart failure, it's not so much it's collagen, but what we have is called the NT-proBNP, which is a peptide or a type of protein that has been kind of leaked out into the bloodstream if somebody is in congestive heart failure, right? So heart failure, in essence, is basically any type of dysfunction of the cardiac cycle in terms of control, either by contractility of the cardiac muscles or the stiffening of the muscle walls of the heart. But the end result is the limitation or the reduction of forward flow. So when that happens, you get basically congestion, right, of and fluid retention build up over time within the body. So when that happens, you can also have dilation of the heart, eventually causing this particular protein that we can measure via a blood test called the NT-proBNP. So the higher the number, that means the worse your clinical symptoms of heart failure become. So I'm not quite sure about the collagen aspect
Mm-hmm.
of heart failure, but in general, right, anything that we consume, anything that we eat uh, that retain fluid essentially can worsen the heart failure symptomatology, right?
Mm.
So the end results of fluid retention within the body is having too much or too excessive fluid within the intravascular space or extracellular space. In the lungs, right, we call it pulmonary edema. You have too much water inside the lungs tissues, then that will cause limitation between gas exchanges and things like that. So that will cause the patient to be very short of breath. Um, Basically, it's very similar to being drowning in your own fluid kind of situation, right?
Well,
If you have too much fluid inside the lungs, you're going to get also fluid accumulation in the legs. We call it lower extremities edema, and etc. So to answer the question, yes, any type of diet that can retain fluid will worsen the heart failure symptoms. So there is a list of things that we kind of counsel patient on what to avoid when somebody is having a diagnosis of heart failure, so that we can keep their level of fluid being even. So that's the term we call euvolemia, meaning we want to keep your fluid level, not too excessive, but not also too little. Because if you have too little fluids, then you run into the problem of dehydration,
mm-hmm.
right? So that's the opposite of having too much fluid. So the art of treating heart failure patient is to maintain their fluid level at an optimal level so that they don't become dehydrated nor becoming too much volume overloaded.
Mm-hmm. So then for people who are, I do want to ask you too, and we'll get to that though, how you got to be where you are. But for patients or people in general, maybe they're not a patient yet for you, would be what are some of the really early signs of heart failure that they should look out for that maybe aren't something that you would see on a typical Google search?
Right. So any time in general, right, the symptoms of worsening heart failure are fluid retention. So anything kind of related to that is a good indication that patients are accumulating water or fluids. Low extremity edema. So all of a sudden, you cannot fit your shoes, right? So you wake up one morning and the shoes are too small. You cannot fit your feet. So you may have, we call it swelling of the ankles, feet edema, or let's say you used to be able to climb up one flight of stairs and all of a sudden you get winded halfway there, right? So exertional shortness of breath or dyspnea. That's also a hallmark of heart failure. Um, the inability to have a good night of sleep all of a sudden, right? For example, because you have too much water, let's say, inside the pulmonary space, patients, if lying flat, sleeping flat, they would get worsening shortness of breath. So they would compensate by having more pillows, right? So instead of having one pillow, let's say a week before, now you're requiring two pillows to sleep, right, to be more comfortable. So those are sort of like those obvious signs of worsening or of kind of fluid accumulation within the body. But it's really hard to identify the exact timing without sort of our assistance in terms of what we do from a heart failure team. There are tools that we can use to monitor because let's say if somebody starts to experience these symptoms, the actual symptoms, obvious signs of heart failure, the body essentially started to accumulate fluid or retain fluid about 30 days before that. Like if you imagine, let's say you're sitting here and you're looking at the roof of the ceiling, for example, and you see water stain, right? For the ceiling to have the stain, right, the roof leakage probably happened before that, right? So seeing the stain doesn't mean that the leakage happened at that point in time. So usually, same thing with the analogy with the heart, usually the body starts to retain fluid way before the actual obvious symptoms occur. So these days we do have tools that we can detect that. We can, may not be the best time to go into all the tools that we have, but we do have the tools. So if, you're having any of these symptoms, you might want to talk to your doctor about, how to explore these different options. The idea is to basically the hallmarks of treating heart failure, there are basically three, right? So number one is to extend life as much as possible. Number two, to keep patients out of the hospital, right? Because anytime somebody gets into the hospital, their longevity decreases via several trials instead that have been done to demonstrate that. And number three, if we cannot achieve the first two, at least trying to maintain the way things are and keeping things not getting worse, right? So those are the three hallmarks, in my opinion, of what we do, and we do have a lot of option these days. I think we live in a period of time for which we have a lot of new therapies for heart failure treatments. In the past, let's say even 15 years ago, when I was still in training, right, having a diagnosis of heart failure was similar to having a diagnosis of cancer. Some form of cancer is actually more treatable than heart failure. The mortality rate was very high. However, if you look at the progression of therapies, and I'm talking about medical therapies within the last 10 years have changed that sort of trajectory. So now patients are actually able to live, much longer than before. For example, we call them pillars of heart failure treatment. So if your patients are being put on these therapies appropriately, obviously, um, then again, based on data, we can potentially add, approximately 5 to 10 years, compared to prior, right,
Mm-hmm.
to their longevity, which is tremendous amount
Yeah.
of time, to tell somebody that you can potentially, right, not absolutely, but potentially live longer if you could be on these medications. So we live in a very exciting time, in my mind, in terms of heart failure medical treatment. But the art of it is knowing when to give these medications, and you have to balance between cost and the reality of each individual patient as well, right? Because these medications do run higher costs than uh, before, because they are newer medications. So anything newer medication, if they're still on patent, then it's not as accessible as generic medications. But there are ways that we can help to lower the cost, right? So at places like big institutions, usually they have foundations, they have programs to help patients that cannot have access. Even the drug companies themselves sometimes will have programs to help these patients, because it is not good to withhold these good therapies, right, from patients, even though the cost may be the limiting factor. So there's a lot of effort, into making the cost accessible
Mm-hmm.
overall. But in general, I think we are in a good space in terms of heart failure treatment overall.
So you used that analogy of water damage on the ceiling of a house, as there's been so much fluid retention in the body that you're starting to see tissue damage in the cardiovascular system.
Right.
Does that also involve cardiac remodeling and, just for layman's terms, the stiffening and
Yeah.
growth of the walls of the heart?
Mm-hmm.
Uh, is that in any way reversible? Because I liken that to, say, if someone smoked cigarettes for a very long time and they stopped smoking. They can visually see that the black tissue of the lungs eventually becomes healthy and pink again. Is there anything in cardiovascular medicine or treatments that could reverse that sort of thing from happening?
Absolutely, yeah. So in cardiac care, the term that we usually use is remodeling, as you mentioned, right? So remodeling could be happening in two different ways. One is negative remodeling, the other one is positive remodeling. And the hallmarks of remodeling basically is the fibrotic process of tissue, right, or scarring process, basically. Um, so yes, one of the hallmarks of these medical therapies now is, again, it's not a guarantee, right? Because everyone responds very differently to medications. But one of the hallmarks of treating heart failure in general is you want to have these positive remodeling, basically meaning the modification of scar formation, right? So if you look at how muscle fibers contract,
Mm-hmm.
essentially it's, again, I like analogies just because it helped me kind of understand the microvascular space that we look at, that we don't see, right? But if you equate that to what we see on an everyday basis, it's kind of understandable, easier to understand. So look at the contractility of muscle fibers. The way I think of it is very similar to a weaving machine, right? So for that to work perfectly, they have to be aligned perfectly. All the muscle fibers have to be parallel, and then they slide past each other and things like that to be very efficient. When you have scar or fibrotic changes, what happens is you disrupt sort of the alignment of these muscle fibers, and then they become inefficient, right? They're not going to be able to slide past each other more efficiently, and they sort of, that's why you have the reduction in the strength of the heart or the muscle fibers. So a lot of these medication, what they do is they kind of realign that in some sense, right? There's no way for us to kind of see exactly what they do, but from trials and including animal models and things like that, we know that these medications do help with sort of realignment of these scar formation, either minimizing them, organize the scar, so that the muscle fiber become more efficient. Now, what we can see from a macro point of view, though, is that we do see um, the improvement in the actual pumping mechanism of the heart ventricle, right? So again, inside the heart, the left ventricle is the main pump. In heart failure, with the reduced strength, right, the heart is not squeezing all the way in. You can see it's doing this. But with medications, after a certain amount of time, you can actually see on ultrasound. So we use ultrasound machine or technique to look at the pump function of the heart. You can actually see the heart vigorously beat again, right?
Whoa.
So that is a demonstration to me when that happens, um, um, that there is some,
You're like,
positive
yeah.
remodeling to help the heart functions to restore itself or recover from being weakened in the past. So yes, so we do see that. And a lot of these medication in combination, not just one or two, but in combination, contribute to that sort of process.
And you wouldn't necessarily, when you say a positive outcome like that, you wouldn't call that healing per se, would you?
I would say that's healing. Yeah,
Okay.
that means the heart has healed, right?
Yeah.
To some extent. Now, whether or not it's the complete process of healing, we don't know for sure, right? Just like if you have a cut on your hand, right? Um, you may have the scar still, but if your scar, gets healed better, then the function of your hands may be preserved, right? So that's what we see sometime with the cardiac muscles.
Okay. And you mentioned in the last 10 years there have been some new pillars that you've used as the benchmarker for treating heart failure for generically maybe most of your patients. What are some of those pivotal products, or I shouldn't say products, but medicines that you use?
Yeah, basically there are classes of medications, right? For our audiences that might not be aware of the medical terms, I'm not going to try to go into the details of it because we don't want to use a specific example. But what I would say is classes of medications, right? So you have the beta blockers, which are there to lower the heart rate and the blood pressure. That's been shown to be very beneficial. That was actually one of the earliest class of medication that was approved to treat heart failure with reduced ejection fraction. To go back though, before talking further about the specific types of medication, there are two types of heart failure. Okay, I think we haven't talked about that. One is the reduced ejection fraction, which is your heart actually weakened. Um, again, the analogy is, let's say you have a truck that run on a V8 engine and now it's a V4, right? So you're losing some capacity or some strength of that engine, right? But there are also type of heart failure that you have a V8 engine that's still on the V8 engine, but it's just inefficient, right? It's not pumping the blood forward, even though the strength of the heart is actually, preserved, is normal. So we call it heart failure with preserved ejection fraction. So that is more of a complicated syndrome, if you will. It's not just one disease that's causing that syndrome. It's many factors. It could be high blood pressure. It could be arrhythmias. It could be obesity, induced, or a combination of all the above. So there's two types of heart failure in general. In terms of medications that are the pillars of treating heart failure, we are talking about the type of reduced ejection fraction. Okay, so that's what we're focusing on. The treatment for heart failure to preserve ejection fraction, though, is more complicated. It has to do a lot with modification of the risk factor rather than attacking, the heart function or the myocyte themselves. But there are still therapies available for that, but it's a little more common. So let's focus on the reduced ejection fraction type. And when talking about that, there are four classes of medications in general. We talk about the beta blockers, and then the second one would be the ARNI, ARNI. That's the classification, and then the third would be the SGLT2 inhibitor, right? And the fourth is the spironolactone, eplerenone, in specific, those kind of medications that affects the hormonal pathway in general. So,
Not to interrupt you, but the spironolactone, aldactone, those ones,
yeah,
the ending, those are all diuretics?
they do have diuretic effect
Okay.
because they do work in that RAS system, and part of that in the renal vasculature that can affect the fluid sort of excretion or diuretic, meaning removing of fluid away from the body. But they also can have some effect on remodeling as well. Yeah.
Okay.
So that's and it has, and if used in conjunction with other medicine, then the effects gets amplified. Okay. And then the SGLT2 inhibitor, so that class of medication is the one that actually removes sugar away from the body, right? Because by moving sugar, excreting sugar into the urine by osmosis, you're actually drawing fluid out as well into the urine. So that also has some diuretic effect in addition to the actual removal of sugar. Sugar is known to be very inflammatory, very bad overall, so excess sugar. So by removing that altogether from the body, actually also helped with some remodeling process, although we don't know for sure at this point. But we do know by trial design that they do help to improve survival in these patients. So that's the new class of medication, SGLT2 inhibitor. ARNI is a little bit more complicated. It's worked within the RAS system. Again, it's part of the kidneys pathway, and it's now also been shown to be beneficial, positive remodeling. So these are the 4 classes of medication that we have available. Back in the days, even 10 years ago, so ARNI came out onto the market about 10 years ago. SGLT2 came out about about 5 years ago. The good thing about these 2 classes of medications is they're actually at the end point of their patent. So they're actually getting generic. So I'm very thankful for that, because now we, in the very near future, we really don't have to worry about the cost of these medications, and we can, more people would be able to afford at a lower cost. So that's exciting also to look forward to. I think within the next year or so, it's going to be a lot cheaper.
Yeah, that's very exciting. Okay, so let's jump into more so HFpEF. I recently watched a video about that, and that one has more association with cardiac remodeling per se. Is that correct?
Indirectly and directly,
Okay.
right? So HFpEF, again, is an entity. I like to think of it as a syndrome, not a disease, right? So in medicine, a disease process is one particular process that is causing the problem. So that's a disease. Syndrome is a constellation of different things, an umbrella of different problems causing the same effect at the end of the day, right? Causing the same sort of symptoms at the end of the day. So that to me is what HFpEF is. As mentioned a little bit earlier, it's a complex sort of is a complex entity syndrome, if you think about it. A lot of it has to do with other risk factor associating with it. Okay, so we know that obesity can also lead to heart failure with preserved ejection fraction. We know that uncontrolled hypertension over time will also lead to heart failure with preserved ejection fraction. We also know obstructive sleep apnea can also lead to heart failure, preserved ejection fraction, right? So therefore, in terms of HFpEF, if you look at the classification of drug right now, the only one that indicated to treat that is actually the SGLT2 inhibitor class of medication. And again, how does that work, right? So SGLT2 inhibitor, what it does is it removes excess sugar away from the body. So if you can think about sort of from a common sense pragmatic standpoint, by removing excess of sugar away from the body, you're removing some of the bad sort of components that can affect that syndrome, right? Could be inflammation, it could be a little bit of excess weight, it could be, etc. So then has been shown to be beneficial for that purpose. So that also kind of proves or point towards the idea that weight loss actually might be very helpful in these populations, because we see a lot of HFpEF patients have a what we call concomitant comorbidity of obesity, and then the obesity syndrome can cause other problems, right? Lead to diabetes, high blood pressure, obstructive sleep apnea. So, in my mind, to be pragmatic and just to be realistic, I think if we can reduce the incidence or prevalence of obesity in our society, I think that will also help to reduce the incidence and prevalence of heart failure, preserve ejection fraction overall. Okay, and heart failure reduce ejection fraction as well. But specifically for the HFpEF population, that will also help tremendously. And there are trials actually are looking at that right now. As we all know, there has been an explosion, right, of these weight loss drug or diabetic drug that causes weight loss within the last 3 or 4 years, and now we are seeing the linkage between obesity and heart failure, especially preserved ejection fraction. So we are not us in particular, but in the medical community, there are trials that have been conducted to look at specifically putting patients on these drugs, see how they do in terms of their heart failure outcomes. So that's pretty exciting as well.
Yeah, definitely. Yeah, I mean, referring to the GLP-GIP agonists that are out there. I mean, that's been a concept that I've been pondering recently, which was just metabolic dysfunction related to cardiovascular health. And within your patient population, this can't exactly be extrapolated to apply to the general population, but within your population, how often do you see metabolic dysfunction, and maybe not even obesity, or diabetes, but just in general metabolic dysfunction in your patients who have heart failure or any cardiovascular diseases?
I would say there's a strong correlation,
Yeah.
right, with metabolic dysfunction leading into heart disease in general, right? I like to kind of connect the dots, right? Nothing in my mind in cardiac space is an isolated event, right? Everything is kind of interconnected in terms of risk factors, in terms of like we were mentioning about before prior, the fibrosis and things like that. So everything kind of interconnected, and it's a slow process, right? It doesn't. That's why you see a lot of, well, in the past, right, heart disease tend to happen later on in life. But if you notice within our modern societies, as more patients are not as active, more patients are, having weight issues and things like that, more patients are having metabolic syndrome, you're now seeing, patients are having heart disease at an earlier age. We're talking about in the 30s and 40s now, right? So there is definitely a linkage or relationship directly related between metabolic syndrome and cardiovascular disease in general.
Yeah, I mean, it's kind of grim to think about, but every year I see screening ages get younger and younger, and disease rates keep creeping into ages 20s and 30s. I was chatting with someone today. She has a client who's in her mid-30s and has stage 4 colorectal cancer.
Yeah.
And it's just wild to me. But I think 20 years ago, that would have been the most outlying statistic you could think of.
Right.
But it becomes more common all the time.
But on a more optimistic note, though, even though we're seeing younger patients having cardiac problems, but because of our advances in medical therapy and technology within cardiology, and for that matter, in the medical community, we're actually seeing more patients living longer as well. Yeah. So, I mean, to give you an example, and it's not a, there's no data at this point to kind of, but from my own experience, back in the days, 15 years ago when I was in training, if you saw somebody, in the 80s, you'd be like, oh, that's really good, excellent genes. But these days, I have a lot of patients in my office, and this is within the last 5 years that are approaching 90s or even in their 90s. Healthy, good quality of life. 90-year-old patients out in the community. So we do see that as well. So I would say that one thing about our society that I appreciate a lot, in my opinion, is the research and development efforts been put into the problem that to try to correct the problem and try to improve things, right? So that's the reason why I'm seeing more 90-year-old patients, healthy 90-year-old patients walking around, which is a tremendous benefit for us.
Mm-hmm. That's really cool. So as far as lifestyle and longevity, I'm very intrigued by biohacking.
Yeah.
I don't know if you're familiar. The first time we recorded this, we talked about sauna.
Right.
And cardiovascular health. I did actually find a clinical trial that found a positive benefit from sauna in addition to exercise. So the test group was just exercise, or the control group was just exercise. The test group was exercise with 15 minutes of sauna. Lowered cholesterol, blood pressure overall. There really wasn't any impact that was noteworthy or statistically significant for weight loss from the sauna, but cardiovascular system overall just functioned better. What are your thoughts on that and how that would work? Because that's extreme heat. It was 15 minutes was the post-exercise group.
It's hard to extrapolate, right? Specific reasons from one trial, but in general, right? There are principles that I kind of observe over time. And one of the good sort of example that I've been thinking about or looking into is the blue zone, right? So if you talk about longevity, blue zones are regions around the world that have higher percentage of the population living longer lives, right? Longer years in life. Now you wonder, I was wondering, so what are the features, because they have come from different society, different places around the world, different culture and different people, right? But what are the common sort of features that they all share? And if you look at those populations or those communities, there are two things that jump out of my mind that kind of validate or kind of give us some insight into what are those features. Number one is being active, right? So these communities, they do a lot of walking. They walk everywhere. One in Japan, there's one in Loma Linda, right, in the U.S., and in Southern California. They try to walk to the store. They try to walk to their neighbor's house. So, in essence, being active, right, cardiovascularly actually helps. So maybe with the sauna, you're increasing your heart rate. You're trying to sort of, to me, it may be a imitation of some form of cardiovascular exercise, right? We don't know. But walking in those communities is one of the hallmarks of their lives, right? They walk everywhere. They try to walk everywhere. And the second thing, in my mind, jump out is the sense of mental health, belonging. So a lot of these communities are very close knit. They have a strong sense of community, right? Loma Linda is religious based, but in, let's say, the Japanese, community, they live in a small village and everyone trying to help out. They're very close. So in a sense, mental health is also very important. If you look at, so that means that their stress level is really low, right? So maybe, right? So applying that to the sauna situation, maybe, again, this is not evidence-based, right? This is just me
anecdotal
kind of connecting the dots. Perhaps mental health play a big part of longevity as well. And that's one of the reasons why, in my own life, right, I try to optimize that within our workspace and even at home, right? Mental health is tremendously important to not only physically, we need to be physically fit, but I think mentally fit as well, just to maintain, longevity as long as we can. So I think those are the two things that kind of jump out of my mind on why these people or these communities are living longer, and maybe that can apply to the sauna situation because it's very relaxing to go to a sauna,
Oh
right?
yeah. Yeah. Even
So
if it's just 15
it's a
minutes,
good
it's nice.
de-stressing. Yeah, it's
Yeah.
a very it's a good de-stressing exercise or outing for sure.
Definitely. So you mentioned staying active and walking. Do you exercise? What
Yeah,
is your optimal?
I fitness is one of the things that I think again, one of the most embarrassing things as a cardiologist is having a heart attack, right? A premature heart attack. So I worked really hard to sort of lower the risk, right, for that, my own risk. But yeah, so I look into a lot of different ways to. I used to be very active with, lifting. I want to be like as muscular as possible, and within, about 5 years ago, before that. But found out that was really hard to maintain,
Mm.
and at the same time, having big muscles or muscle mass index might not be as sort of helpful as you think. Like if you look at the people in the blue zone again, you look. There's a documentary on Netflix, I think, about it. They're not muscular, right? They don't look like Arnold Schwarzenegger, right? They just look like normal people, but they
Yeah.
live very long. So they're lean, right? One thing is they look very lean. So I think moderation is important for me. Um, in my opinion, I think walking is the best form of exercise. If you try to be too excessive, right, you develop other problems. Like anything that you do excessively, I think will have side effects. Even exercise, right? So if you run a lot, you might have knee problems. You might have arthritis, early premature arthritis development. But I think exercise by walking continuous has to be continuous, right? You can't just take a step back and forth and rest. But yeah, continuous walking at least an hour a day, for me, is actually very helpful. I don't get a lot of joint pain or anything like that, but I feel like I'm very fit to do that. I feel very, good afterwards. And the other thing is eating healthy. I try to eat healthy, watch the diet. That is actually very important. Um, because again, for the blue zone people, they eat very organic. They grow their own vegetables, and I don't grow my own vegetables, but moderation. They don't overeat. If you look at, listen to interviews and things like that, they eat enough to be full, but not to be overly full, right? Um, Eat enough not to be hungry actually, and not to be full. I think that's what they said. Um, Yes, but you do need a little bit of muscle mass. That's another thing. The muscle mass do burn more calories, right? Do help you to burn calories. We know that. Again, not excessive, right? Just enough. So there was actually a study from Harvard Medical School, and this is actually a brilliant study, and I use this study quite a bit within my own patients. Unfortunately, though, the kind of uh, one sort of negative thing about the study is that it doesn't have female gender incorporated into the study. So what they did was they took about 1,000 firefighters, okay, healthy firefighters in the area of Boston, around Harvard, and they enroll these firefighters. These are men primarily, uh, from active, right? You can range from 40s, any active firefighters. Usually, I think the average age was in the 30s and late 30s, early 40s. And then they follow them for 10 years. And the question they were asking was, there were two questions. Number one, at what level of exercise can these firefighters do to reduce their risk of cardiovascular event? And that is, heart attack primarily. And at what level of exercise they cannot do that predict the higher risk of cardiovascular events. And they use what is the most common form of exercise, low cost. Anybody can do it at home. You don't really have to go out and buy anything for it. Right? They chose push-ups, right? So this is brilliant, right? Push-up anybody can do. It's your own body weight. Lifting your own body weight off the ground. You don't have to go out and buy weights. You don't have to. The list of injuries much less, right, than any other form of exercise or heavy lifting. Anybody, any age can do push-ups. So they basically concluded that anybody that cannot do more than 10 push-ups. So if you do less than 10 push-ups, the risk of cardiac event goes up tremendously. But if anybody, any firefighter within that study were able to do more than 40 push-ups, then the risk is extremely low. So the idea is strength, conditioning, and maybe that's something there, some insight into longevity or some cardiovascular risk factor. So I try to do that. I try to do push-ups every other day or even every day when I'm feel up for it. I can do more than 40 push-ups. So
Wow.
yeah, so I tell my patients, that's one thing that you can do. Obviously, the age group may be a little bit different,
Right.
right? These are younger men. So yeah, I see somebody that comes in to see me having some chest pain. After I rule out everything, I tell them, maybe it's, and then they say, what's the best form of exercise? And maybe it's push-up for men, younger men, middle-aged men. 40 push-ups or more, try to train yourself to do that. Based on that study, it may be beneficial.
Yeah, you sent me that study and it blew my mind. I
Yeah.
told my husband, I was like, you need to do push-ups every day, please.
Yeah, there's some value to it. It's a brilliant study. I mean, it's
Yeah.
cheap. I mean, anybody can do it.
Mm-hmm.
It's one of the things that I actually incorporated that into my practice for sure. Yeah.
That's cool.
Yeah.
So walking and push-ups, those are your go-to.
Yeah, that's
Okay.
it. And I used to lift weights. I used to have a personal trainer that
Yeah.
I go to, a good friend of mine. But it's really hard to maintain that,
Mm-hmm.
like in terms of, and then I start to get pain, muscle pain and things as I get older. And then as you lift heavy weights, right, you always need to, so I get some shoulder pain, I think, on my left shoulder. But ever since I changed my kind of routine, I've been feeling better, and yeah, so.
Yeah. I liken the push-up study to bar workouts. A lot of women do bar workouts. Episode 2 was a lot about bar and Pilates. But bar workouts is all body weight driven. You may add a 2-pound weight here and there.
Right.
But the whole idea is using your body weight to train to failure. And at the beginning, or I should say the end of last year, I kind of stopped weightlifting, and I'm a pretty big weightlifter most of the time, at least 3 to 4 days a week.
Yeah.
I kind of stopped and just did bar and Pilates. And I noticed the soreness was a different kind of soreness because you're tearing different muscle groups that
Yeah.
you don't use as often.
Right.
But in my mind, I was correlating, okay, this push-up study, which is all body weight training, to bar.
Right.
And what sort of cardiovascular benefit, if there is any, could you see from strictly training within that zone of maybe low cardiovascular intensity that you might see when you're walking on a brisk walk, plus the body weight?
Oh, I think it has to be. Now, I'm not an exercise expert by any stretch of the imagination, but from a common sense standpoint, I think anything you do, being active, is actually very beneficial, right, for the cardiovascular health. So if you look at and this is sort of the gauge that I do to understand these things, and by a very simple equation, right, and that is cardiac output equal the stroke volume times the heart rate. Okay, so cardiac output is basically the amount of blood your heart can eject in a certain amount of time. And the stroke volume is how much blood can the heart squeeze in one beat to get it out, and the heart rate is the heart rate. So the idea is, right, if you have high heart rate, if you think about if the heart has to pump faster, then if you have two hearts, if one is pumping slower and the other one is pumping faster, the slower heart pump actually has less wear and tear, right? Just like anything else, is common sense. The higher heart rate actually has more wear and tear. So in order to maintain equal amount of cardiac output, you want your heart rate to be as efficient as your heart muscles to be as efficient as possible, because with every squeeze, you need to maximize the stroke volume, right, to eject the maximum amount of blood so that you don't expend how many times you have to do it, right? So the more efficient, the more volume, stroke volume you get out of one squeeze, the less the heart rate required to maintain the same cardiac output.
Mm-hmm.
Exercise, cardiovascular exercise, does just that, right? It's based on that equation, because by conditioning your heart muscles over time, you're training your heart cardiac cells or muscle cells to be as efficient as possible. So with every squeeze, you're pumping out more fluid, more blood, then you don't have to contract as much. If you look at athletes, for example, right, their resting heart rate in professional athletes in general are slower than the general population for the same reason, because their heart muscles are so conditioned to the point that with every squeeze, they just able to pump out more blood, then they don't have to, you know, pump it as fast. So in general, slower heart rates actually at resting, slow heart rate is actually very beneficial for longevity. So to go back to your question, yes, I do think that there is a correlation. So if you further, right, add exercise regimen onto your routines that will condition your heart. That's why people always say change it up every now and then too, right? You're doing the same exercises all the time, your heart gets used to it, and you're not gonna get as conditioned. So by changing things up, that may help to condition the muscle fiber a lot more efficient over time, and that will help, you know, in terms of optimizing cardiac health, in my opinion.
That's cool. I like that because then the biology is kind of working in the same way, that in a nice way for people who get bored doing the same thing over and over and over again. It's good to mix it up to give that longevity. Okay. The other question that I wanted to ask was about birth control. My generation, a lot of friends everyone's just kind of put the X-nay on all hormonal birth control. And I actually did meet someone recently. She had clots a few months after starting, which, being in pharma, people have asked me questions. I am by no means a doctor, but knowing a little bit about drugs, I always tell people, if they ask me, okay, well, does the benefit that you're going to get from this medication outweigh any of the side effects? If the answer is yes, okay, then perfect, go for it. If not, definitely always talk to your doctor in this situation, but just you as the patient advocating for yourself, really look at the package insert, look at the side effects, and decide for you and talk to your doctor what's best. But in your clinical practice, what are your thoughts on hormonal birth control? Have you seen any crazy adverse events from hormonal birth control? And maybe let's talk about the pill more so in the context, because IUD is much more localized hormones. So let's just keep it in the context of the pill, because it's more whole body
Systemic,
and accessible to a lot more people than an IUD.
Yeah, I do agree 100%. You know, with anything that you want to make a decision on in terms of medications or exogenous substances, if you will, and putting inside the body, it always has to be done with risks and benefits assessment, right? What is, at the end of the day, you want the benefits outweigh the risk, right? So, having said that, birth control pills do play a role in terms of hypercoagulability, meaning in terms of the blood clotting pathway. Okay, so one of the most detrimental, in my opinion, side effect of birth control is having blood clot inside the lungs. We call it pulmonary embolism, you know. And in some cases, right, if you have a lot of pulmonary embolism or blood clot inside the blood vessels of the lungs, that may impede gas exchange, meaning blood flow within the vascular space of the lungs, and that could lead to sudden death, right? So have I seen that happening? Yes. You know, sometimes we call it saddles embolus, you know, that basically the whole branch or the whole entire tree, pulmonary arterial tree, is clotted up with blood clots, and then blood cannot get in or out of that space, and then basically that would lead to sudden death. It's rare, not very common, but when it does happen, though, right, you feel very bad about it because it could mean it is, sudden death for that patient. So have I seen that in practice? Yes, I
Mm.
have seen it, but not very often. Back in training, I saw one case, I think at the Cleveland Clinic that happened, but not recently. But I do see blood clots that are not fatal. That's more common. So you may have blood clots that not plugging the entire arterial tree within the pulmonary vasculature, but maybe you know one or two or a few branches here and there, but blood can still move back and forth. And symptoms of that would be shortness of breath or chest pain. Some chest pain as well associated with that. Um, but even that is not a good thing, right, for it to happen to somebody. So again, it's something that you really have to think about. Now, there are also uh, in the future potential birth control pills for men. You
Mm.
know, now would that have any side effect with this? We don't. I don't. I personally don't know.
Mm.
But that's something to consider too. Not just you know women having to bear these risks, but I think in the future we have to think about us, in terms of sharing the responsibility, if you
Mm-hmm.
will, and carrying the same risk.
Hmm. That's
Yep.
interesting. Do you know what any of the side effects that are listed on those from any clinical trials that have been published so far?
For men,
Yeah.
the men birth control,
Yeah.
I haven't really read. I just saw like a headline recently, like I think 2 months ago, one of the medical websites saying there is now birth control for men being studied, either been studied or has been successfully done in terms of, but waiting for approval or something like that. But I
Mm.
don't know for sure.
Interesting.
Yeah.
Since we're on the topic of pharmacology in a way, if you have a patient who's young and presenting, labs are healthy, you do an echocardiogram, everything's looking pretty normal. Maybe they're still nervous that they're high risk, if they are a high risk patient from strong family history of cardiovascular disease. Is a strong family history, if the patient is otherwise healthy at the moment, is that enough to initiate pharmaceutical intervention now rather than later, almost as if you're kind of foreseeing that happening in the future because the odds are high?
Um, it's part of the risk factors. If you look at, again, we do have tools to assess long-term risk factors, right? We always talk about the 10-year risk factor of cardiac events and primarily heart attack, right? Um, and family history is part of that, but it's not the only factor.
Mm.
Now, so if you are asking, is it the only factor to put somebody on medical therapy? The answer is no, it's not, right? Because any time that I put somebody on medication, regardless of what that medication may be, even aspirin, for example, that which you can buy over the counter, even Tylenol, even aspirin, ibuprofen, right? Any medication will potentially have side effects, right? So then you have to essentially assess again the risks and the benefits.
Mm-hmm.
Even with any type of medication, you got to really think about, is it worth it to put somebody on this particular medications? Because I don't really, I people like to know percent. Oh, this is only 0.1% or 1% risk, but if it happens to somebody, then it becomes 100% for that patient, right? That patient had to deal with that 100% of the time. So to me, you might, from a medical standpoint, you want to minimize that risk as low as possible, and also maximize the benefits. Okay, so yes, so having family history is not, to me, is not good enough. We may have to look into other factors. These days, one of the good things that we have in terms of assessing just for heart cardiac events is getting a calcium score. Okay, I used not to be skeptical of that when it first came out. This is way back in the days, but after being practiced for such a long time, for a while, I have realized that's very beneficial um, in that particular type of patient that you just mentioned, because when you do a CT scan to calculate the calcium score of the heart, if that comes back zero, then the chance of that patient dying of a heart attack within the next 10 years is extremely low.
So
Right.
is the screening interval then to test that? Would you consider it an every 10 years
It
screening
depends on
interval?
the
Depends
patient,
on the patient.
obviously,
Okay.
right? Depends on the risk. I'm just talking about just purely if somebody comes in and quite concerned about, oh yeah, my father had a heart attack when he was, in the 40s, and now the patient in his 40.
Mm-hmm.
Besides looking at everything in terms of EKG findings, looking at the cholesterol, let's say everything is kind of borderline, you really don't know for sure, right?
Mm-hmm.
Maybe the cholesterol is high, but it's not high enough for you to be scared, right, at this point. Um, then I would do a coronary calcium score. It's a CT scan. Most center would charge you, I think, $99 to $150,
Oh,
right?
that's
So
very
you go
reasonable.
in. Um, I don't think insurance covers it, but you can get it. You can pay for your own. It's by cash, and then you get the CT scan. The good, the good sort of use of that scan is actually being zero. If it's zero, that means you're good to go. Then you really don't have to start on medication, if as you were asking. Then I can say, yeah, right now, even though you have the family history, but because your coronary calcium score is zero, perhaps at this point, optimize your exercise, optimize your diet, make sure that you're eating healthy, mental health, optimize your mental health, and then we'll reevaluate in a few years, or if you have symptom, we can come back and see. Another aspect we can do a stress test, also has the similar predicted value. If I put somebody on a treadmill, and it's just plain old treadmill, and if they can exercise on the treadmill, and they're grading that we can grade them in terms of scoring, and if they can optimize, if they get a certain score, I can actually predict whether or not they can have an event within the next 10 years as well. So
Wow.
there are tools that we can use for that. But to me, yeah, stress testing along with the calcium score, coronary calcium score, are actually pretty important to kind of assess the risk overall. In young patients, obviously, you don't want to do anything invasive, right? Because again, anytime we do anything invasive, procedure being the lower risk procedure,
Mm-hmm.
the always risk of complication,
Mm.
right? Again, we want to minimize that or even terminate it, right? Don't even put the patient, expose them to the risk at all, if not if all possible, but still get the benefits of the predictive value. So I think stress testing along with coronary calcium score are pretty important. And which one to do or do both depends on which patient you're talking to, other risk factor involved. Now, with calcium score, you are also exposed, because of the CT scan, you are exposed to some level of radiation. So that's one thing that you should be aware of, or people should be aware of, right? Um, if that is something that people, oh, I don't want to be exposed to radiation, I'm wary of that, then I would do a treadmill stress test. And if the treadmill stress is good result, the risk of having a fatal heart attack is also very low.
Mm. Okay, so we've gone a lot into your experience in clinic, and thank you for regurgitating so much knowledge that you have about
Yeah, no
the
problem.
cardiovascular system. But what made you decide to become a doctor and then also decide to become a cardiologist? Did you always want to go into cardiology, or what was your path?
Yeah, so my uncle is a family doctor in San Jose. So growing up in San Jose, I was exposed, early on to medicine. Just hanging out in his clinic, every summer. I think since middle school, I would volunteer in his office, just trying to, and then shadow my uncle talking to patients. I like that relationship, right? So in my opinion, right, I'm sure uh, there are other professions out there that have similar interaction, but for me, medicine is the one of the few professions that you can actually connect with your patient at a very personal level, but also at a very there's a lot of trust between you and your patients, right? There are things that my patient would like to or when I was kind of observing my uncle, that would share with my uncle very personal things, and that showed complete trust, and I feel like that's a very interesting relationship, right? Not a lot of strangers can do that, right off the bat after meeting somebody for 5 minutes and able to tell the other person a lot about their personal, you know, information or lives. So that was very interesting to me.
Mm.
Not a lot of profession can have that. And in addition to that, we do change people's lives, for the better in general. So that was also very sort of satisfying, if you will. Um, so that made me, becoming very interested in medicine in general. And then when I went to uh, med school, I liked the heart a lot, and because to me the heart is very logical, right? If you look at the physiology or study the physiology of the heart, everything is so logical, including the electrical system, the action potential, the movement of the electrolytes to generate the action potential, the beating of the heart, the mechanics of how the heart's beating. It's very, like, you can actually picture it in your head. Like, once you understand the physiology behind it, you will never forget it. It's
Mm.
one of the classes or organ system when I learned about it that I didn't really have to like memorize too much about it. Like, it's been there for so many like decades after the thousands of years, millions of years through evolution, but it's still there. It's not going to change, right? It's still the same cardiac cycle, still the same mechanisms, the same physiology. There's something constant about it that I like, and then the understanding of it came very easy to me. Um, and I like kids, so I love kids, so I actually wanted to be a pediatric cardiologist
Hmm.
initially. So um, my mentor at the time in med school sent me to do a rotation in pediatric cardiology, and I didn't like it because as a pediatric cardiologist, you have to deal a lot with infants or babies that have a lot of cardiac conditions, right? And these are malformation. They were born with them, and I couldn't handle that. Seeing babies, in the intensive care unit with tubes and things like that. So I came back to um, to my mentor and said, I cannot do cardiac pediatric because that'd be too depressing for me. I don't think I can handle it. And then he's like, have you ever thought about adult cardiology? And I like, why? It's like, oh, it's very simple. There's only a few things you need to worry about in terms of risk factors, which is true. So
Yeah.
there are only 5 things in terms of cardiac, problem. Number one is diabetes, high blood pressure, obesity, cholesterol problem, and also now, sleep apnea. So these are the 5 kind of silent killers in my mind
Mm.
that will kind of lead to cardiac disease over time. So it's like very simple. Those are the things you can modify them. You understand, the physiology behind it already. So I think it should be pretty easy. So I said, okay. So I tried it, and then I went to a rotation with adult cardiology. I really enjoyed it. Patients in general are very pleasant to deal with, right? Because they're older in general. Again, we're talking about cardiac disease. So as you get older, patients do develop cardiac problem. So, and I learn more with my patient too. They can talk about all sorts of things. Like sports, investment advice. All of that. I do learn from my patient quite a bit just from the interaction. Again, that kind of trust between patient and doctor, right? So they wouldn't, for the most part, right? They would want to impress you because so they would tell you the like little things to kind of you wouldn't hear elsewhere. So you learn a
Mhm.
few things from talking to your patient, which is I'm very grateful. So then I decided that I would do that for the rest of my life. So I put in the effort to become a cardiologist after that.
That's cool. I
Yeah.
love that you said that you learn from your patients because I think for me in medical sales, I feel so honored that I get to
Yeah.
work with some of the most intelligent people and well-educated people in the country. And
Right.
then to hear you being one of those people say that you feel that same feeling about your patients. It's just really cool that it's so full
Yeah.
circle, all this sharing of knowledge.
Absolutely. I
Yeah.
mean, I've been practicing, right, more than 10 years now in cardiology, and every patient that I encounter, you learn something from them.
Yeah.
You know, they come from all walks of life. They have so many different experiences that I might never be able to experience. So just listening to stories, learning about, how they would deal with certain situation helped, a lot. So yeah, I do. That's why I love to do clinic, because I love to learn that part, something about my patient all the time. I'm there to help. Obviously, that's the goal, right? But at the same time, I find joy just talking to them or to my patients.
Yeah. So who would you say right now are some of the most inspirational people in your life?
Uh, I think my kids, to start out with, I do feel that I remember somebody, uh, I think there was a podcast I listened to, and he's like, I always have pictures of my kids on my desk
Mm-hmm.
because when I want to make a decision about something, um, I'm looking at the pictures to remind me would my decision positively or negatively affect my kids, and I would make the decision accordingly. So I think that speaks for me as well, right? So I think family is very important. Uh, my kids, my wife, my wife stays basically very dedicated to raising our kids. I'm very busy, so I'm really appreciative of the effort and the time that she puts in, to have the kids, needs met and everything. So yeah, so my family is my inspiration, Um, my wife is the sort of central figure in that whole aspect of my life outside of medicine, because I think she's a partner, right? We share decisions, but there's a lot of things she does better than me, and that in essentially raising kids and taking care of the kids. So, and then my my partners that I work with, I think next and but not least, you know, having again going back to that mental health aspect of life, I think working with people that you like to work with and respect. One thing about cardiology you mentioned also, about working in general in the medical field, is that you are surrounded by people are very similar to you, right? In terms of your aspirations, in terms of your experiences. And most importantly, I learn a lot from my partners too, right? Because we share the same passion, we share the same experiences, but everyone's different in terms of how they would handle certain aspects of their lives. So I do learn that as well. Different style of seeing patient. Like sometime I would, oh, he's doing this way because, so I would adopt that, right? So yeah, so my partners in general, just having good partners around or good people working with you, I think very important. Um, so I'm very simple, and then I have a smaller groups of friends that I trust from different aspect. One other thing that we may be talking about later is I do feel one of the important aspect of sort of being successful is having people around you that you can learn from too, right? Um, and anybody at any time can learn something from other people, regardless of who you are. There are always new things to learn. So I try to accommodate myself with another group of friends that are not necessarily within my circle in terms of working with me, but similar mindset, but maybe older, maybe more experienced in a certain aspect of their lives, and then I learn from them.
Mm-hmm.
So that's also very important.
So you gave me some good advice when we were at the Renowned Trends conference
Mm-hmm.
last fall, and well, it was just great to spend so much time with you and in more of a fun setting at a conference, but also you gave me some good advice about real estate.
Mm-hmm.
But before we jump into that aspect of your kind of side hustle that you have going, is advice that you would have for young adults who are hungry for success in life and in their careers and relationships. what kind of advice would you give them?
So it may be very cliche, but I honestly feel that you have to do what you love to do, right? I mean, it's been said so many times by other people, but I find it very true because you don't want whatever you do is like a chore to you or a responsibility, right? You want to do um, to work in an environment for which you feel this is what it's fun for you to do, right? To be able to keep it going, to be able to excel at what you do. So find that passion, right? Um, the second thing is dedication, okay? In my opinion, a lot of successful people that I'm surrounding myself with, my friends that are very successful, they didn't become successful because of luck or because of uh, spontaneity, right? Randomness, right? They put the work into it, right? So one of my good friends, Jim, he's a very successful investor, um, real estate, even more successful than me in terms um, of volumes and things like that. He literally read over 30 books on how to be a successful investor. When we first met, he gave me a list of the books that he read that helped him to make decision because a lot of these to be successful is all about decision making, right? Yes, there's some luck involved in terms of the right place, the right time, but you have to make the right decision. So you have to be able to prepare yourself so that when you're in that right place and the right time to make the right decision because you don't want to miss that opportunity. So that what Jim taught me is later on is reading books. So he put he put the work into it, right, to prepare himself. So when opportunities happen, so one of the thing um, that I learned from that is always be ready to jump on the opportunities that will come about. And and you have to have a vision also. And the only way to have that vision is to read books, to learn what other successful people think, right? Because you got to be creative. Same circumstance, if you don't have that vision, you may not see what the opportunity may be for you,
Mm-hmm.
right? I'll give you a um, very good example of that. When I was trained in training at USC, there was an initiative of so USC, as you know, even the health campus is surrounded by not very desirable neighborhoods, right? Even the main campus, if you go out of the main campus, the surrounding neighborhoods are not they're not it's not Beverly Hills, right?
Mm-hmm.
Same thing with the health campus. So USC putting a lot of effort into incorporating the neighborhoods of surrounding their campuses to make it better environment to live, more inviting for people to be a part of it. So they had an initiatives that anybody who works at USC would be able to receive a grant, um, either by renting a place or by buying a place. USC would pay for part of it so that you can live around USC. So you don't have to like live in a more well-off neighborhoods. Lots of people didn't want to do that, but when I looked at it, I said, wow, this is fantastic, right? I'm going to be a fellow. I work a lot. I don't need to be at home all the time. So I bought my first place around the campus, USC campus, and that within the zone. So I literally went onto the website looking at the map of the boundaries of all these places to make sure I fall within the zone that USC would support. And I bought a condo, around there. That was my first condo that I bought. It turned out to be one of the greatest investments. At the time, the price was low. Nobody was really into that neighborhood because it wasn't that, safe. But it's still close to the campus, the health campus, walk-in distance. Right now, we're renting it out to medical students. They would live there, very well maintained. The value keeps on increasing in terms of LA market, always goes up. So again, not being able to see that, right? So not the program was there, but nobody's really, very few people saw that, right? But we saw that and we jumped on it. So that's been very successful. That one example, right? Seeing things differently, right? Not necessarily, not everyone I was seeing. Be thinking outside the box a little bit, be proactive, be a little bit creative.
Yeah.
Yeah.
Well, something that I find very intriguing about you is that you also only sleep for maybe 4 to 6 hours every night.
Yeah.
The 4 hours of sleep, especially, I mean, how often is that happening? Is that more common than the 6 hours?
I would say on average 4 to 6, maybe 5 hours. I could function very well with just 5 hours of sleep.
Yeah.
When I was younger, like in med school, yeah, I could sleep for 4 hours, no problem. I used to go into anatomy lab by myself in the morning. That's when it's all quiet, nobody was around. I would just sneak in there at 4 o'clock, 4:30 in the morning, just learn the anatomy, memorize the parts. Um, so I would go to sleep at like 11 midnight, wake up at 3 or 4, and go and learn anatomy.
Wow.
Yeah. So yeah, it's actually very interesting. If you look at I think there's about 20% of the general population that can do that. I think Jay Leno might be one of them. He mentioned that in the past. I think President Trump might be one of them as well. Um, I think people like us, I think it just gives us a lot more time. It's not that we're smart or anything. It just have more time for us. Like I have more time to read up on things, like to go to the anatomy lab, to put more time, effort into learning, at the time. So my mom is like that too. She would wake up in the morning. I remember like every time we visited someone or we go, like she would be the first one, like cleaning the kitchen or cooking, it's 5 or 6 in the morning. She can't sleep more than, she actually cannot sleep for more than 4 hours. She wakes up like that after 4 hours. And she's been very productive all her lives too. Yeah.
Wow.
So.
Well, it sounds like you have as well.
Yeah, yeah.
So now with all of your extra time, what do you do since you're not in school obviously anymore?
Yeah, I read up on investing,
Okay.
things that sort of, yeah, I mean, in terms of medicine, I think medicine is good in a way that it provides you the stability, right? But, um, you know, you always need to be more secure, I guess, right? So I think having that extra time helps to learn up on, for example, I remember, so this is another story in terms of Tesla. So when I was in fellowship. I remember this very vividly. This was about 12 years ago. I walked into the ICU at the hospital I was training at, and I suddenly saw a large group of people gathering around. And I thought, what is going on? So I walked up, and then I saw my attending at the time were talking about Tesla. So I think he was one of the first doctors of the entire hospital that bought a Tesla. And I think at the time, now with inflation and everything, I think it was about 100 grand, the car. But he was the first one. So everyone was excited. He was excited to talk about it. Everyone was very excited to learn about it. I remember he wore this jacket with the Tesla sign on it. And then I didn't know what it was at the time, but then curiosity struck, and so I went and listened in the conversation. I'm like, wow, this is something very interesting. But at the time, as a fellow, trainee basically to become a real doctor, I didn't have the means to buy a Tesla, right? So it struck me, what if I buy the stock of Tesla, right? If I cannot afford the Tesla, but there's so much excitement here. And yes, so I spent the extra time learning about it. I learned who Elon Musk, I didn't know who he was. And oh, this is the PayPal guy. So he now doing Tesla. So he already had a track record of success. So I'm like, okay. So I actually bought a lot of money that I had left, like after expenses, very little, but I just bought a whole bunch of Tesla stock at the time, continue to do so. So that was actually one of the biggest investment that I made that actually has the biggest return, was because of that.
Wow.
Yeah, so extra time. So I did some research,
Mm-hmm.
got online, look up Elon, look at Tesla, kind of learn everything about him, and say, well, this may be something good to do. So I pulled the trigger on it, and now it's been very successful.
Mm-hmm. Well, you're kind of cueing me a little bit for this next one. It's definitely not one I asked you the first time we recorded, but are you excited about, or what are your thoughts more so on what we're expecting to see from new regulations in food related to healthcare with the new administration? Are you anticipating big things? Are you hoping, this massive health epidemic might get a little bit of a handle on it? Or what are your thoughts?
I I don't have a lot of thoughts, but what in general, right? I'm more like a big picture person. I
Yeah.
think overall, I do feel no matter what political spectrum you're on, I do believe in our system in a way, right? So I do feel that um, in a country like us, I think we're still the number one country in the world,
Mm-hmm.
right? For um, I teach my kids every day, America is your motherland, is your country, because this is the best place for you to be, you know. The one thing I don't like is, people saying, "Oh, because I don't agree with this, therefore I'm going to leave." And my take on that is, yeah, if you don't like something, just stay and work it out. Make it better for everyone and yourself, right? So work at it. So that's my own philosophy. But overall, I don't. Doesn't matter. I think what administration is in power. I do feel that as a whole, the system is actually a great system, right? Uh, Research and development is still happening. Patients are still getting good medical care. Um, Obviously, one might argue plus and minuses depends on where you're from, right? What angle, what lens you look into. But from the whole overall picture, from my standpoint, right? I've been doing it, practicing medicine through different administrations, and I don't feel a big difference in terms of the quality of care that we can
Mm-hmm.
deliver for patients. Obviously, there are policies that may affect us in terms of how do we manage our care, how do we deliver the care, but the quality overall to me hasn't been negatively affected, right?
Mm-hmm.
So patients are living longer, like I was saying,
Yeah.
right, from my own experiences. Um, so I do feel that we have a lot of good people within our system to ensure that. You talk about the food regulations, safeties, and things. Um, but obviously, in any type of environment, things get magnified, in terms of uh, one little thing get blown up into bigger issues. But I think overall, I think we're fine. I don't have any negative expectations. I think moving forward, I think our country, just like the stock market, right? It's gonna be up and down, up and down. But if you look at the trajectory of it, it's always gonna go up.
Mm-hmm.
Even the downturn is always gonna be better than the previous upturn, if you will, right? Anything else. And um, for the same token, I think it's gonna be okay.
Okay. I like it.
Yeah.
Uh, so what kind of, I mean, we talked about the status of the country. We just talked about what you want from your patients, what you do for them. What kind of lifestyle are you and your wife developing for your kids so that they can grow up to be the healthiest, most accomplishing individuals that they can be?
Yeah, be as active as possible. The most important thing that we try to teach our kids is moderation.
Mm-hmm.
You know, I'm not sure if this applies to most families, but I know for our own family, being from an Asian background, grandparents, for example, always want to sort of overindulge, right? The grandchildren, right?
Yeah.
So eat more, or you know. So my teaching with my kids is moderation. Like we don't force our kids to, for example, overeat, right? Like when we eat, we tell our kids, if you feel full, you don't have to eat, right? If you look at the natural survival instincts of humans, people eat when they're hungry.
Mm-hmm.
That's just like kids when they're hungry, like infants or babies, they cry because they want to eat, they want to survive. So if my kids don't want to eat, it's probably they're not, except when they're sick or something, that's different. But healthy wise, they don't need to eat. They're not hungry. So yeah, we don't overindulge. We don't. So everything in moderation and being active. So we try to walk. My kids like to play the video game these days, but but whenever I can, I at least take them out, walk for an hour or so. They do boxing, so they do
Oh,
go to
cool.
boxing. So all of them go do boxing classes. They go swimming classes. So lots of exercise,
Mm-hmm.
cardiovascular exercises. Boxing is primarily for self-defense and also for some cardiovascular exercises too. Yeah, so just get them active as early as possible, right? That's one thing about our society that I think growing up is the more we are relying on computers and AIs and things, the more we take away from the exposure of natural environments. So we try to expose that to them.
Yeah.
Yeah.
What's been the most rewarding part of fatherhood, and how has it shaped you as a person?
Um, you always have to think about how they model themselves after you,
Mm.
right? So that's a big responsibility. Um, and it so in general, you could say that I'm more of a risk taker than most in terms of anything like with investment or with any other activities. But having kids around kind of put a perspective in you, right? Meaning your decision making becomes more on a safer side. Like back before having kids, I'm always more inclined to make that big jump or, you know, make that big decision. But nowadays, when making a decision, we always have to look at would that change anything. So it makes you feel a little bit more guarded in terms of what you want to do and less about you, more so than the whole family.
Mm-hmm.
My wife also, along with that, even investments, right? Wise, like we don't want to jump on into anything that would more potentially lose money, even though we would rather make a little bit of money, but not, uh, but less likely to lose a lot of money. So,
Mm-hmm.
so it's more careful. Um, it's just natural. It's hard to say, that bond. Looking at somebody that kind of look like you, it's very interesting.
Yeah.
Like, oh, okay. You kind of look like me. I look at my picture when I was younger, and like my youngest son kind of looked like that. So I'm like, okay, that's interesting.
Personality wise, do you see a lot of yourself in your kids, or is it kind
Yeah,
of, yeah,
I do.
yeah,
Yeah, absolutely. They all have a little bit of traits. Yeah, both my wife and I are mixed in. But it's interesting though. I have three kids. They're all very different.
mm-hmm.
It's same family, same teaching, same parents, same household, same environment, but they do have a little bit of deviation from one another. So which is very interesting. One could be very introverted. One could be very extroverted. One could be very neutral, right? So it's kind of making you looking at things a little bit differently. Like not everything is exactly the same kind of situation.
Mm-hmm. Mm-hmm.
Yeah, very dynamic.
Yeah, that's fun. I don't have kids of my own, but I'm excited to eventually have
Yeah.
them. Okay, we talked about, oh yeah, the other things that we wanted to talk about. So magnesium, we chatted about that last
Mm-hmm.
time. It's been kind of trending in a way,
Yeah.
magnesium. I love it for sleep and
Mm-hmm.
muscle recovery. And then also you mentioned cardiovascular health
Yeah.
last time.
Mm-hmm.
Can we dive into that a little bit?
Yeah.
Yeah.
So I don't know what it is, but I've been noticing within the last few years, especially after COVID, I have seen, excuse me, a lot more younger patients that come in with palpitations.
Mm.
Okay, so palpitations are symptoms of racing heart rate. Sometimes you feel like, irregular heartbeats. Sometimes the heart can jump out of your chest. You feel some, palpitating sensation at the neck area. For young people, I'm talking about young people, right? 40 or less, or maybe early 40s, okay, 20s also. The prime, a majority of those cases are what we call premature heartbeats. Okay, it could be from the ventricle or from the atrium, but premature heartbeat. They're usually benign, but they could be very symptomatic. So for whatever reason, after COVID, we've been seeing a lot of those, especially for me personally, young patient coming in with that. Magnesium, in my mind, have been very successful for me personally, um, because most patients, when they're young, they don't want to take any medications that could, slow them down. Because a lot of medication that can treat that actually can slow your heart rate, decrease your, causing some fogginess kind of scenario. Um, Magnesium, though, for some, not all. This doesn't is not a one size fits all, but for some young patients, magnesium really helps to kind of control those symptoms. Okay, obviously those could be provoked by alcohol, caffeine, stress, etc. But in addition to modifying those factors, magnesium, in my mind, is a natural supplement. You can buy it. It's very hard to overdose on it, but don't take that to heart. Anything you take can be overdosed, but magnesium relatively safe, um, and it's actually helped to regulate those arrhythmias for the patient. So uh, I'm a big believer, in magnesium, and yes, it does help with sleeping a little bit, right at nighttime. I take magnesium myself. I do have PACs and PVCs myself, and magnesium does help quite a bit for myself personally. So it's a good supplement. And talk about supplements in general, I don't do supplements because I give somebody medications or prescribe medication. It has to be done with trials, tested to make sure it's safe. So I rarely endorse, any type of supplement. But the only two that I would say are worth thinking about. Number one is vitamin D, and number two is magnesium for me. You know, we live in Reno, right? Our winter months are really kind of shorter, so you get less exposure. It's cold, so I do take vitamin D during the winter months just to keep my mood up a little bit. So it does help.
Yeah, yeah. I've heard that too for combating the seasonal depression. Or they call it now. It's like some acronym, not seasonal depression, but SAD is the acronym. I can't remember what it stands for. I was like, wow, good job, marketing team.
Yeah.
That was great.
Right.
The seasonal SAD. Then the other part of the vibe check, that's a big part of the whole mission here,
Yeah.
is faith in, and well, we keep it open kind of in anything.
Yeah.
If you are a man of God, and I want to chat about that a little bit, and then also how you maybe can apply your faith to your clinical practice as well.
So I am fortunate in a way, in my mind, that I have been directly exposed to a few different faith in the world, right? So initially, I grew up in a household of Buddhism, right? So my parents are Buddhists, still practicing Buddhists. So I grew up with them, going to the Buddhist temple and things like that. And if you think about Buddhism, you think about relationship to the Hinduism part of it, right? So similar. And then when I went to college at UC San Diego, we had, as part of our core curriculum, we had to take humanities. Basically, it's a 5 semesters uh, uh, courses of humanities, reading text from ancient civilization up to current civilization, right? So, or ancient time up to now. So one of the requirement was to read the Bibles, and basically Old Testament and the New Testament. So we literally read that thoroughly. So I studied the Old Testament and the New Testament, and then throughout life, growing up, going to med school, and under first fellowship, and get exposed to different religion. From the people that you hang out with. Judaism, Muslim, Christianity. One of my roommate back in undergrad was actually a very a Christian, have a very strong Christian faith. I attended a few Bible study with him. Ultimately, I am I a man of faith? Absolutely. Okay. I do believe that there is uh, a being out there that is more powerful than us, that knows more than us, that determine uh, life, uh, or sort of knows kind of the steps of life, if you will, right? As a doctor, that realization actually has become more confirmative over the years. Back in the days, when you're training and you're in med school, you believe that you know everything, you read all the texts and you have all the answers, right? But as you are practicing medicine, or I am practicing medicine throughout recently, more and more you realize that what you know might not be exactly how it will happen, right? So, for example, there are a lot of patients that I think may not be able to live for a long time, but they end up, living more than expected, healthy. But there are patients that I would say, well, it's you're probably going to be fine. We did all the tests and everything, um, but yet they still end up having a fatal heart attack or a dissection of the aorta, out of the blue, which no one knew about. So there's a lot of unanswered phenomenon that I think that sort of humbled me, that made me realize that these days, the way I sort of looking at things is that I am an extension of God's plan, if you will, right? So uh, God's put me here for a purpose, right? And through me, whatever it is, I'm going to do the best I can. But the outcome of what I do or how I do it is not up to me, right? That up to God determination at the end of the day, His plan that you don't know about, right? So that sort of helped me to, in some way, right, cope with some of the things that disappointment in terms of treating patients. Yet, yeah, in the cardiology world, people do die, uh, from the cardiac diseases that are present. And in the past, you always want to look for answer. Like, let's say somebody dies suddenly, right? You always like, what happened? Like, what's going on? But as more and more, like for example, when talking about learning about from patients, like one of my patients, very close patient, died unexpectedly, and I called his wife and I talked to him. So his wife told me, yeah, so and so died, and I just want to let you know we appreciate your care over the years. And I called her just to talk to her, and then I was telling her that's just so unexpected. I thought he would be able to live until for another 5-10 years, no problem. And then she was like, Dr. Toe, don't feel bad. He knew that, and he lived life to the fullest. He enjoyed your company. Whatever happened, he accepted it, and the whole family was a very strong faith family, and then this is what she said that kind of struck me. This happened early on, is that what? You don't know if this is good or bad for him. He may be, he's with, he besides God, right? He may be in a better place than you. How do you know that it's bad, right?
Yeah.
So she basically told me that, and it struck me, right? Like different perspectives, right? So having faith, I think, very important in terms of understanding the bigger meaning of everything happening, around us. But from my personal standpoint, I do the best I can, and I think of it as a way to executing or to carrying out, the plans that He has, right? So.
That being said, have you seen any medical miracles where you feel super confident that that was just God's hand at work, that you were not expecting that outcome, and there's no other way to explain it, but maybe
Absolutely.
that? Yeah.
Not only God's hand, but it's um, I had a patient that this is so I was doing a procedure on the patient, and her heart stopped beating. Okay, we couldn't explain it. That's one thing about this whole thing. Usually, you can say, you can look at the cases and kind of find out, but we review the case and nobody really know the cause of it. Everything, yeah, maybe this the reason, maybe that's the reason. But so we did CPR and everything. The patient survived, and a week later, um, when I was talking to her, and she looked at me and said, "Dr. Toe, I want you to redo that procedure for me." Right? And then I looked at her and I was like, "You you almost died, you know, and luckily we revived you." And she basically became normal, like her mentation,
Hmm.
everything. Usually when somebody had CPR, you know, they have some downtime, there's a chance that their mental state may be affected in a negative way. But for this particular patient, everything is completely normal. Okay, like nothing happened. And then I looked at my patient. It's like, "Are you sure?" And then she goes, "Yes, Dr. Toe, because I trust you, and God trusts you." That's what she said.
Wow.
You know, so so we did the procedure again. Everything went well, and then she actually got a lot better afterwards. Um, in terms of her overall uh, um, clinical expectation, you know, we didn't expect her to survive, but she did. But that made me realize that there is something more powerful at hand in that circumstance, right? The will to sort of go through it again, the trust, right? And mind you, this is like these are completely two strangers, right? Yeah, she's been my patient for you know, I met her about 2 or 3 years, but you know, with two different backgrounds, two different, you know, circumstances. But for her to have that trust in me, for you know, and then when it after what happened, right, it made me realize that what we do is much more than that, right? Like there's something else going on that we don't fully understand, you know. So that really, so that made me feel like everything I do, I have to do the best I can, right? Because there's a bigger responsibility, if you will, right? For me to be able to do this, because not everybody can do it, right? So so there's a big responsibility for that. So I take it very seriously because of that.
There's a concept that I've been kind of toying with that's kind of related to that, where it could be a lot of pressure on someone in your field to not mess it up. But even in my day-to-day life, finding the strength in faith takes a lot of the pressure off of me to perform in that way. Is that kind of what you were getting at? Is that you kind of, you know that this is the path you were meant to be on, and so it takes the pressure off of that really stressful part of performing in a way?
Yes, but that's why by doing it, by perfecting it, by putting your work into it, takes away that stress, right? Because, like for example, for me, when I was in residency, um, in order to know or to learn all these concepts, or I read the textbook from front to back, you know, and then in fellowship for cardiology training, I also read the textbook front to back, you know. So by doing so, you're just understanding the basics, the fundamentals behind it, and giving yourself the best chance to do the best you can, right? So when complication happens or something, then you can tell yourself, I that the best I can. There's no, like, you don't feel that you left something behind, that, oh, maybe I should have read up on more on it so that I didn't make the mistakes, right? So that's my advice, is also trying to do if you don't know something, don't do it. If you don't know something fully, understand something fully, don't do it. Don't do it halfway, right? You got to understand, you got to put your effort into it, because there's always a possibility of bad things happen. And when bad things, you can do 100, 1,000 cases, 10,000 cases. If one case goes bad, something happened to that. Doesn't I don't care who you are. If you have a conscience, you're gonna feel very bad about it.
Mm-hmm.
Even though you helped 9,999 patients, but that one patient that you didn't, and something happened to him, maybe unexpected. Maybe it's not any, you know, but you still gonna feel bad about it, right? Because it's human life we're dealing with. Um, so you have to be prepared the best you can. So then, obviously, have a conversation with your patient and everything else. But when that happened, then you think back and say, you know, that I don't think there's anything else I would have done differently to change that outcome, for example, right? It's not that you bring closure to yourself, that would be selfish, but also to the patient and the family, you know. When people die, I think the person that died, actually the least affected,
Mm-hmm.
right? So I see so many cases for which when somebody died, it's the family,
Yeah.
that left behind that has to deal with all of that. So to answer your question, when we do something, we want to maximize the efforts. We want to make sure that everything we do wouldn't affect, whoever left behind if something bad happened.
Mm-hmm. Mm-hmm.
So.
It gives me so much hope because my family was devastated by losing our dad from cardiovascular death. It's just sudden heart attack. There was no, I guess, when the paramedics came, they were able to not revive him, but get a heartbeat back, but he was gone. And for us to know something like that, I know that those paramedics did everything that they could because they did get his heartbeat back.
Yep.
But he was gone. And it gives me so much hope because I look at specifically the SGLT2s because I've scoured his autopsy like a weirdo and looked at all the clinical data from SGLT2s.
Right.
And he was already on the standard of care that was available for heart failure. And I think he had HFpEF. And that was really weird because understanding HFpEF it's interesting to me, but I mean, he had hypertension and a lot of stress. So looking at all these other risk factors and piecing them all together, and every single time I was just like, oh, man, an SGLT2 could have given us a few more years.
Yeah.
So it's really gives me so much hope, though, to see that there are more medications coming out now in the next couple of years and what have come out in the last 5 to 10 years that have given people more time with their families, and how rewarding that you get to be the one to decide, okay,
Right.
what's the best way to give them more time.
Yeah, I think from my perspective, right, I'm in the space, or I think the new approach that I have about these medications, they're very hopeful, they're very optimistic for the future, but at the same time, my approach to them is a conversation with the patients, right? Because in the new era of information, we don't want to be um, forcing something on our patients in general, right? Because if you look at all the data, not everybody on these medications actually get the benefits, right? It's a percentage, right? You compare two groups of people, but not 100%. And even if the medication, there are still, events happen, right? So it doesn't really, but you're right, it does add more lives. It does potentially reduce the event's chance of happening. So that's all about the conversation that we need to have with, and that's for the audience and the listener as well. Is that whenever you make a decision, don't be afraid to look at that conversation with your provider or your doctor as a collaboration of discussion. Okay, it's not about, like, I don't want to look at it as I am forcing the patient to do it, right? It's all about the risks and the benefits again. To talk to the patients to help them understand the risks and the benefits, and then have them make that decision. Because ultimately, I always tell my patient, you are the one who knows yourself the best, not us. But on the other side of the coin, I feel like some doctors don't spend enough time to explain that aspect, right? Uh, the benefits, and also see the negatives of it, right? So you have to be balanced. You have to be presenting two sides of the story, and have the patient decide on what they want to do. Because again, the most important aspect or take home message is, even though they're good medicine, but they're not an 100% absolute, medication that will. So when I talk about these aspects, I always use the word potential, maybe or perhaps. It's not never an absolute, and it's a decision-making partnership.
So from the patient perspective in that case, because you have the wealth of knowledge from the clinical and medical background, ways that I've been helping people that I love empower themselves when they do go to the doctor with a problem is, okay, how similar are you to the patients in that clinical trial? Is that valid to consider as a patient if the clinical, like we were talking about
Right.
the firefighters, and they were all male and they were all
Exactly.
relatively
Yeah.
healthy.
Yeah.
We can't necessarily apply that to
Yep.
someone like me who's a woman. Like,
Absolutely.
yeah.
Yep. So yeah, absolutely. Good point, Catherine. So for the same token, right? When you introducing medication to somebody, right? Keep in mind that the patient in front of you is never going to be the exact patient that the trial studied, right? This is from inference, basically, right? Yeah, because we live in the same society, we eat the same food, maybe not, right? Um, Therefore, we may have the same effect, right? But it's not exactly the same. Absolutely correct. So, so it's all. That's why I want to emphasize. Um, it's all about collaboration, decision making. And for the most part, it does work because I've seen it worked in my practice. I do see improvement. I do see changes within their cardiac myocytes, contractility, and things like that, or the function of the heart based on the ultrasound. So I do see it. But yeah, but it's not 100%. There are patients still, even though they're on the good therapies, all of them, they're still not improving, right? So it again, it's all about discussion between patient and doctors.
And then another part of that I always tell people, and this is specifically with this GLP boom, I don't know, reading up on it, they did as they were working through the approval process on GLPs, they test them on rats. And rats that were pregnant or female, a large majority, I don't want to say all, but a large majority of them had pregnancy complications, either like a dysfunctioning fetus in some kind, or
Malformation,
malformation. Thank you.
congenital disease.
Yes,
Yeah.
it really affected the rat babies, and obviously no one is ever going to test pregnant women, so we will never know. Thank God that no one's going to test pregnant women. But risk factors like that, it freaks me out to consider, okay, not every patient is going to go into the weeds like I did and read into that and think about fertility in that way. But that's not always going to come up in conversation. So for patients that are looking into a medication that they're considering, or providers have recommended and they're kind of on the fence, where do you recommend that they go to really educate themselves and feel more confident in aligning themselves with what the provider is recommending? Like where should they start?
I think there are two ways to go about it, right? Number one is to get a second opinion within the people of the same field, right? So if, let's say if you go in to see a cardiologist and it recommends this medication, and if you see another cardiologist and he recommends the same medication, more likely than not, it's probably a good thing, right?
Mm-hmm.
But so that's one thing, is to get the same opinion or a different opinion within the same field of expert, right? To me, is very important because, um, you know, medicine is one, it's not always, but there's some standardization, obviously. There are always outliners, right? If you look at the bell curve distribution. But for the most part, I think medicine is very well standardized, meaning cardiology in general, very well standardized, very protocolized. So for the most part, if one cardiologist recommends something, unless it's not controversial product, usually it's the same across the board, right? So
Mm-hmm.
let's say somebody has high cholesterol, most cardiologists would recommend to treat that with a statin, for example, right? Very few would say, yeah, don't do it, and things like that. Depends on circumstances, obviously. If all criteria are met, most would agree on the same point. So yeah, so get a second opinion, expert in the same field of the expert. Secondly, would be reputable sources, in terms of articles, right? Um, I personally will go to the trials that were conducted. Let's say if a medication is on the market for
Mm-hmm.
this, where did that come from, right? It has to come from somewhere, in terms of, because in America, an FDA approved usually has, especially if a class one indication, if something that potentially can save life, usually, or 100% of the time, that drug has been studied
Mm-hmm.
extensively. There's some trial on it already. So then I would go and try to look up on those trial and try to interpret the data, right? Given if you have some scientific background and some research background, you can look at it. Now, it's it's hard to read an opinion article on something, because when somebody writes an opinion article on something, in general, it rarely applies to an individual, right?
Mm-hmm.
Because if somebody writes something, it usually targets a mass population in generalization. It's not very specific. Not that they're wrong, but it's just that it's not specific enough, right? It just serves as a backbone. So if you really want to dig deep into something, I don't think opinion articles are a good source for that, right? Um, the third thing I uh, would try to sort of gather information from is from a source that you trust. In terms of, maybe you have a doctor friend, maybe you have somebody that you trust, that you've been asked question before and you think that it's correct, um, or your own doctor, but in a different field,
Mm-hmm.
right? So that's sometimes like primary care, for example. Primary care doctors are very good of knowing, well, in my opinion, right, they have to know a lot more than us because they cover a wide range of topics.
Mm-hmm.
So having a family doctor, primary care doctor, is very essential, in my opinion. So if you have any um, question, that may be a good place to start,
Mm-hmm.
right? If you have any doubt, would be a good place to start, because number one, he or she is your doctor. He or she wants you to do well. And if, in general, if somebody doesn't know something, they're gonna tell you. They're not gonna try to make things up, and we all have our conscience in medicine, so they're gonna say they're gonna point you towards the right source also,
Mm-hmm.
right? So I would say usually avoid generalization, but try to look for the specifics.
Mm-hmm.
It's hard to say, but
Yeah, I do really want to give a quick shout out to all the family care providers
yeah,
and primary care providers, because there's a lot of statistics on the coverage gaps that they are kind of forced to fill.
mm-hmm.
Like there's a shortage of nephrologists in this country. There's a
Yeah,
shortage of GIs. I mean, a lot of really important specialties. There's a
mm-hmm.
shortage of those providers, and then the legwork oftentimes falls onto those primary care providers. And they're so, I mean, you're like you said, they have to look at the whole big picture, and that's a hard thing to do. So if anybody out there is listening and they are a family care provider, thank you for what you do, and helping your patient out, because those coverage gaps, I mean, you're filling them, and that's really awesome. So
Yeah, they're the first line of
yeah,
defense, basically,
yeah,
right? So
yeah,
very important,
yeah.
especially during COVID. I mean, a lot of the frontline care was actually provided by, at least from my own experience, by family or primary care providers, in our community, right? So as cardiologists, like, um, we were helping out in the inpatient setting, primarily, but out in the outpatient setting, which has a lot more burden, in my opinion, because there's a lot more patient that were not seeking care inpatient or in the hospital, but out in the public uh, outpatient setting. I think primary care provider had to put up a lot of efforts to care for those patients. So yeah.
Yeah, definitely. Definitely. Well, I want to wrap it up with the trademark of the vibe check, which is fulfillment. And that doesn't necessarily mean happiness, uh, but what is the most fulfilling part of your life right now? Meaning, what gets you up in the morning, and when you have a bad day, what do you lean on to get you through?
I was thinking about this today. Now, besides family, obviously, right?
Yeah.
But in terms of, is it just being in clinic with my patients? I honestly, in cardiology, a high stress environment, right? We care for really high risk patients, and patients do have bad outcomes sometimes. Um, but just having the human interaction, like today, I saw my clinic. I was in clinic and I saw a few patients of mine. Just chatting with them, listening to their story, and then be able to kind of prescribe a medication, maybe helping them. Actually, that's very fulfilling. I'm like, okay, it's just a basic things, um, but it's sort of very constant satisfaction, because one after another you're helping people, right? It's like reinforcement for me. So yeah, just interacting with my patients uh, is very fulfilling for me on a daily basis. And like I said, we learn. Like today, I actually spent about a good amount of time just after the visit was done. We addressed all the questions and everything, clinical questions. We were talking about the Niners, for a good amount of time,
Yeah.
and I was like thinking about this whole subject within the last few days, the quarterback, salary and everything, contract, and then we was just hitting it up by talking about the same thing, like we had the same ideas and everything, just and then out of nowhere. So it was very, very satisfying, very fun, So takes away all the stress, just having somebody like-minded talking about it randomly with you,
Yeah.
in the middle of your workday,
Yeah.
So that's pretty phenomenal.
Yeah.
Stranger, complete stranger. That was a new patient. I never seen that patient before.
Oh, wow.
Yeah, so just bonding over the topic. Yeah, very, very fulfilling.
Yeah. Cool. Well, thank you. Thank you so much for your time.
Yeah,
And
thanks for having me.
yeah, thank you everyone for listening.